So here's an discuss. We'll start with the definition and the epidemiology. We'll discuss the types and how it's classified, the risk factors, the symptoms and signs, investigations, and how severity is assessed, the management and follow-up. So what is pneumonia? It's an infection of the lung parenchyma associated with clinical features of infection like fever or productive cough and new radiologic findings. WHO reported it as being the most common communicable disease causing death in the year 2016. Mortality ranges between 5 and 12%, and it can be up to 50% in patients who are admitted in the ICU due to a severe infection. The picture shows normal alveoli when there's pneumonia. The normal alveoli are obviously air space filled areas, and when there's pneumonia, there's an inflammatory exudate in the alveoli. So the exudate is composed of neutrophils, usually neutrophils, and sometimes lymphocytes. The types of pneumonia, there are three means of classifying pneumonia. Depending on how it presents, it's classified into typical and atypical. Depending on what kind of organisms are involved, it's classified into bacterial, viral, and fungal. Um, and depending on how the patient acquires it from the community, it's classified into community acquired, hospital acquired, and vent associated. So hospital acquired pneumonia is that which a patient acquires after admission to hospital, and it is diagnosed, and it appears clinically 48 hours after being admitted to hospital. So if a patient develops pneumonia one day after admission, it's not hospital acquired. Uh, for it to be labeled as HAP or hospital acquired pneumonia, it has to present 48 hours after admission to hospital. The same goes for ventilator associated. It should present 48 hours after being intubated, that is, after being ventilated, 48 hours after the ETT is passed. We'll be discussing community acquired pneumonia today. So, what are the risk factors that predispose a patient to pneumonia? Smoking or COPD due to other causes, which makes the lungs structurally damaged and leads to a higher propensity to acquire pneumonia. Patients who are diabetics or immunosuppressed because of other reasons, because of malignancies or steroids or HIV, are also more prone to developing pneumonia. Other than that, elderly people or nursing home residents usually, or patients who are semi-comatose or drowsy, they are likely to aspirate gastric contents or aspirate oral cavity contents into the tracheobronchial tree, and then which leads to a mixed infection. Alcoholics are also more likely to aspirate, plus they're also immunocompromised, so they are also at more risk of developing pneumonia. The main symptoms a patient presents with include fever, a cough which may be productive or dry. The patient may have pleuritic chest pain, maybe dyspneic. Some types of pneumonia lead to extrapulmonary features like diarrhea, abdominal pain, headache, confusion, or rash. Signs that you may see on examination include fever. In case of typical pneumonia, the temperature is usually above 39 degrees centigrade. The patient may be tachycardic, tachypneic. If a patient has severe pneumonia, he may also be hypoxic. And on the chest examination, in case of lobar pneumonia, there may be reduced breath sounds with bronchial breathing, crackles, dullness to percussion, and increased vocal resonance. Plus, there may be signs, extrapulmonary signs also in case of multi-system involvement. So, diagnosis rests on the presence of signs and symptoms of infection, features of chest infection, and examination of the chest, which may show new signs, signs that were previously not there, and there may be new, and the chest X-ray which shows new changes, and there is no other explanation for these changes. Investigation that you get done, if for a patient, if you're suspecting pneumonia, you get a chest X-ray to see how the extent of damage and the kind of damage, the blood counts to look for for leukocytosis or leukopenia, and ABGs to look for the degree of respiratory failure, and inflammatory markers like CRP and procalcitonin usually point to a bacterial infection, and their changes in their levels over a period of few days or indicate how the patient is recovering. Also get urea, albumin, LFTs to look for multi-system involvement. These are also prognostic indicators. Blood cultures and sputum cultures are taken for patients who are admitted to hospital and ideally taken before giving the first antibiotic shot. Urinary antigens for streptococcus and Legionella are taken if the main cultures, the blood and sputum cultures, do not show results. And if there is an associated pleural effusion, then fluid is also taken for analysis and culture. CT chest is usually not indicated, but if you're suspecting in other complications, other pathology underlying carcinoma or maybe empyema or um, bronchiectasis, then a CT chest is recommended. So, what is the difference between atypical and typical pneumonia? So, typical pneumonia is said to occur when there are specific features of chest infection. The onset is acute with the fever, chest pain, and a usually productive cough, whereas atypical pneumonia is caused uh, by organisms. It usually presents in a subacute way and is associated with multi-system involvement. The cough may be dry, and other systems that may be involved include the abdomen and the CNS. So the patient may have headache, abdominal pain, diarrhea, body aches. So a typical pneumonia usually shows lobar or segmental consolidation on chest X-ray, whereas an atypical pneumonia shows patchy interstitial opacity. So and often the opacities are multilobar. So there's infiltration in the interlobular septa, which leads to interstitial opacities. The organisms that cause typical pneumonia are usually strep pneumonia, Haemophilus influenza, Moraxella. Haemophilus and Moraxella are common among patients with COPD. Strep pneumonia is common among patients with diabetes, COPD, and among alcoholics. Staph aureus is common among IV drug abusers. Klebsiella is common among diabetics. Mixed infections with anaerobes patients who have aspirated. And whereas atypical pneumonia occurs due to organisms like Mycoplasma, Chlamydia, Legionella, and different viruses like influenza, varicella, the respiratory syncytial virus, and rhinovirus. Other organisms like Coxiella and Chlamydia may or can also cause pneumonia. So, a history of being exposed to sheep and birds should also be taken. These atypical organisms do not grow on routine culture media. So, if samples are sent for cultures, there's usually no growth, but you will have signs of infection on chest X-ray or on examination. So, treatment should be able to cover these organisms. The organisms that cause typical pneumonia grow on routine culture media, but still the culture yield is low on in practice because patients have already taken antibiotics, or generally blood cultures are not very sensitive. So, but if there is a growth, usually it's strep pneumonia, Haemophilus, Moraxella, Klebsiella. So these are the differences between typical and atypical pneumonias. Here's an X-ray comparison of the two pneumonias. When you say there is a lobar consolidation, it means that it's a specific lobe that is involved, and it's clearly homogeneous opacification of that lobe, as you see here. When there's atypical pneumonia, there's interstitial shadowing or patchy infiltrates, as you see here. There's no dense, specific, clearly localized area of consolidation. It's just a patchy haziness or interstitial shadowing. Another picture here, as you see, there's interstitial opacification throughout, more so um, on the right lung field, it's throughout from top to bottom, and here it's more in the lower zones. And here this is the dense consolidation of lobar pneumonia. So this is said to be atypical, and this is said to be atypical, and B, and this is said to be typical lobar pneumonia. So there are means of assessing severity of these patients, so they can be stratified, and management can be decided as to where to treat the patient at home or in the hospital general ward or in the hospital ICU. So there are a number of scores that have been designed to test for to look for severity. Curve 65 is one of the very simple scores, but it misses one important point, that's hypoxia. The PSI covers many features. It includes comorbs, the sodium levels, the um, VP, the mean arterial pressure. It covers many things, and the smart cop also covers many things. We'll see how many parameters it covers. Then there are the major and minor criteria given by the Infectious Disease Society of America in 2007, and then republished in 2016. This is the curve 65, a very simple score that requires just one lab. The rest of the features are those you can see on examination. So 1 point is given for the presence of confusion or a high urea level that's more than 42 mg per dl or more than 7 millimoles per liter. A high respiratory rate of 30 breaths per minute or more, a low BP less than 90 or less than 60 diastolic. So 1 point is given for that, and for a patient aged older than 65 years. So depending on the scores, these are the risk groups. So for a score from 0 to 1, the patient is taken as low risk and given oral antibiotics and sent home, managed at home. For a patient who has a score of 2, patient can be admitted or sent home with close observation and instructions to return if he deteriorates. For a score from 3 to 5, patients are taken as severe CAP and they're managed in the ICU, ideally managed in the ICU. So as the score increases, the 30-day mortality increases with a significantly increased mortality at scores from 3 to 5. So this score misses one important thing, hypoxia. Sometimes in practice we see patients with a very low score, 0 or 1 maybe, but they are hypoxic, so you cannot take them as an outpatient. The patient has to be admitted if the patient is hypoxic. Here's the smart cop score. Takes into account the systolic blood pressure, the presence of multilobar infiltrates on the chest X-ray. It also takes into account albumin, low albumin levels, a high respiratory rate, tachycardia, the presence of confusion in a patient. Very commonly, elderly patients present with confusion and no fever. So confusion is an important feature. It also takes into account the oxygen saturation, which if it's less than 90% or the PaO2 and the ABGs is less than 60. or it takes into account the PO2 FiO2 ratio, which if less than 250 gives 2 points for oxygen desaturation. And a low pH also gets 2 points, less than 7.35. So for patients with the score of up to 2, the risk of requiring intensive respiratory and ventilatory support is low. As you go higher up, the risk of the risk of uh, requiring support increases. So for scores that are more than 5 are taken as patients who need ICU admission so that they can be given respiratory and vasopressor support. These are the IDSA criteria for ICU admission. For them, it's if one major criterion is present, then the patient is a candidate for ICU admission, or if there are three or more minor criteria, then also the patient is a candidate for ICU admission. So the major criteria are the requirement for endotracheal intubation, mechanical ventilation, and the need for vasopressor support to maintain BP. Other criteria that are included in the minor include the vitals, the respiratory rate, the BP, the oxygen saturations, low PO2 FiO2 ratio, the presence of multilobar infiltrates, if there's confusion, the urea nitrogen, low blood counts, low WBC counts, low platelet counts, and low temperature. All of these features are features that indicate the presence of severe CAP. So there are multiple systems used to score patients and assess severity and therefore and guide management. Since it's an infection, the main management is to give antibiotics. So for outpatients, it's going to be oral antibiotics for 5 to 7 days, along with antipyretics if there's fever or body ache. And for inpatients, it's oral or IV antibiotics, depending on whether the patient is able to take orally. And if the patients are drowsy or comatose, then it's IV antibiotics, and then they're shifted to oral antibiotic as soon as they're able to take orally, they're able to digest, and they're conscious. Along with that, analgesia, antipyretics as required, IV hydration as required, because patients who are in sepsis require hydration, and oxygen therapy if the patient requires oxygen if he's hypoxic, and mechanical ventilation if patients are getting fatigued because of an increased respiratory rate. They need to be mechanically ventilated. Plus venous thromboembolism prophylaxis, because these patients are um, critical. They're kept immobilized in the hospitals. If they mobilize, they tend to desaturate. So prophylaxis is to be given if they are in the hospital and immobilized for more than 3 days. A longer duration of antibiotic treatment has to be given if longer than 7 days, if the patient is immunocompromised, or if there is infection at other sites, like if there's endocarditis or meningitis, or if the initial empiric regimen that has been given turns out to be ineffective against the organisms that have grown on culture. So the choice of antibiotic depends on the presence of comorbs and whether the patient is being treated as an out or as an inpatient. So for outpatients with no comorbs, the idea is to cover most of the typical organisms and some of the atypical. So amoxicillin, azithromycin, clarithromycin, and doxycycline. These agents cover most of the typical and some atypical organisms. So you can choose between any of these three agents. For outpatients that have comorbids or are immunosuppressed because of any kind of immunosuppression, like if they're HIV, or if they have diabetes, or um, if they have malignancies. So two agents need to be given, coamoxiclav along with a macrolide or doxycycline. This is one option. And the other option is to give a single fluoroquinolone, that is a respiratory fluoroquinolone, moxifloxacin, or levofloxacin. So it's either single agent with quinolone or double agent with coamoxiclav plus macrolide or coamoxiclav plus doxycycline. For inpatients who have non-severe CAP, severity assessment based on the IDSA criteria. So for non-severe CAP, it's IV antibiotic like ceftriaxone or cefotaxime or ampicillin plus sulbactam. These are beta-lactams. So one beta-lactam agent and one of macrolide and doxycycline. So two agents. Similarly, just the way we gave for outpatients with comorbs, we gave either one beta-lactam with a macrolide, or we gave one quinolone. So it's the same way, with the difference that the beta-lactam here is IV. So beta-lactam with one other agent, or you give single agent moxi or levofloxacin. For ICU patients, two agents need to be given, one beta-lactam, those discussed earlier, like cefotaxime, ceftriaxone, or ampicillin sulbactam, together with a macrolide or a fluoroquinolone. And if you are suspecting Pseudomonas infection, for instance, in patients who have structural lung disease like bronchiectasis or um, especially bronchiectasis or COPD, or if there have been previous culture growths with Pseudomonas, then it's highly likely that this time also the patient is going to have Pseudomonas. So then you have to give an anti-pseudomonal penicillin like tazobactam piperacillin or ceftazidime or cefepime or meropenem or imipenem. These agents cover Pseudomonas. If you're suspecting MRSA, that is methicillin-resistant Staph aureus, for instance, if there have been previous culture reports with Staph aureus growth, with MRSA growth, or if the patient is not responding to conventional antibiotics, then you can give vancomycin or linezolid for MRSA. And if it's the influenza season, then it's advisable to give oral oseltamivir or zanamivir if the patient has initially presented with a flu-like illness. So it may be an influenza pneumonia. Patients usually respond in 2 to 3 days. For instance, their fever may settle down without, they may have no fever without antipyretic agents. Their cough may improve. Uh, so if patients do not clinically improve by 72 hours, or their CRP, the C-reactive protein at day 3 doesn't drop by 50%, it's still very high. It's still above 50% of baseline. That is the initial level at diagnosis. Then you should look for reasons why the patient may not be responding. Sometimes it's usually just the host factors. For instance, the patient may be elderly with a weak immune system, or may have comorbs, or may have HIV, may have hypogammaglobulinemia, or may have structural lung disease, already damaged lungs, because of which the patient may be slow to respond. Other than that, the patient may have developed complications. For instance, there may be a parapneumonic effusion, a simple or a complicated one, or there may be an empyema or an abscess, of the patient may be going into ARDS. Patient may have septicemia with hematogenous seeding in other organ systems, like they may have endocarditis, meningitis, or they may have developed renal failure or an MI, because of which they may be going further downhill. Other points to consider may be that the initial diagnosis is not correct. Maybe it was just a pulmonary edema or a pulmonary embolism that is being managed as pneumonia, or the patient may have vasculitis or a carcinoma, or metastatic lesions in the chest, that may look like pneumonia on chest X-ray. There may be cryptogenic organizing pneumonia, eosinophilic pneumonia, or drug-induced lung damage, which may all which may all show alveolar shadowing on chest X-ray, and may not would obviously not respond to antibiotic. Other reasons that may why a patient may not be responding may be because the antibiotics are inappropriate for the pathogen that is causing the pneumonia. So the organism may be resistant or atypical, or maybe there may be a different organism altogether. It may you must consider TB or fungal infection or nocardia. So these organisms are resistant to So these organisms are resistant to conventional antibiotics. Follow-up imaging is generally not indicated if the patient is clinically improving, and because the chest X-ray takes a long time to resolve, from 2 to 6 weeks. So if the patient has improved, there's no need to get a repeat X-ray. But there are certain indications for repeat X-ray with or without a CT chest. uh, there are two main indications. One is that the patient is still having symptoms despite taking antibiotic treatment for a long time, for 1 to 2 weeks. And if the patient is at risk for malignancy, for instance, if the patient has a history of being a heavy smoker, or if the patient is elderly, or has had weight loss over the past few months, so must consider a repeat chest X-ray with or without a CT chest as appropriate. Prevention is to vaccination is done to prevent pneumonia. Influenza vaccine is generally recommended for all people above 6 months of age. So for different ages, they have different vaccines. For very young children, they have the age appropriate vaccine should be given, and it's the annual influenza vaccine that comes in August to September and should be given by December every year. And pneumococcal vaccine is not recommended for everybody. It's recommended for certain high-risk people, and it is effective for the next 5 years. So people who are above 65 years of age, people whose spleen, who are anatomically or functionally asplenic, uh, like patients with sickle cell disease who are functionally asplenic, and patients with renal, cardiac, liver, or lung disease, those immunosuppressed for any reason, which it may be still HIV or malignancy, hematologic malignancies, other malignancies, diabetes. So these patients should get the pneumococcal vaccine every 5 years. These vaccines are recommended because they reduce hospital admissions and hospital deaths due to pneumonia. I hope this sums up the topic for you. Thank you for your attention.